Welcome to SNF This, the podcast where we pull back the bed sheets on skilled nursing facilities, educating, entertaining, and occasionally risking being reported to HR.
Awesome. Welcome to this episode of SNF This. I am excited. My new friend, we just met.
Yeah.
Not too long ago, but I've heard great things about her and I'm excited to talk about kind of her expertise and things she's learning. But let's start with, who are you?
Yeah.
Like your story, how'd you get into healthcare? Specifically, kind of how you got into the space you're at. And yeah, we'll start there and then we'll jump into some other exciting topics. But
yeah. Thank you. Thank you for having me.
Oh,
this is
super excited to have you.
So my name is Vimmi Panchal. I am from Philadelphia. I work for an academic center and I wanted to take care of geriatric patients because I started taking care of my grandparents.
Oh, interesting.
And that kind of led to different paths. One, we did hospice at home.
Okay.
That's how she passed. And then on my other grandmother, we did the nursing home with a PEG, with Alzheimer's diagnosis, the whole other.
Yeah.
And it's kind of like
so
seeing
hard.
those two sides. I'm like, you know what? End of life can be very different for people.
Yeah.
And even managing it during when we were taking them to appointments to help translate and things like that. So that was always fascinating to me. And geriatrics was always a calling. So I did my
Awesome.
fellowship and I stayed in geriatrics.
So where did you do your medical training?
I did my medical training in Antigua,
Okay, nice.
Yep.
And then fellowship where?
fellowship at Penn.
Awesome.
Yeah.
That's great education, great background.
Yeah.
Yeah, so we were talking, I'm interested in, you guys have a unique kind of platform and situation at your academic center where you have you call it an ACE. Is that what
Yeah.
you're calling it? Tell
yeah.
us a little bit more about that and kind of what you do there. And
It's awesome. It's acute care of the elderly. So it's a closed
Okay.
unit where we have physical therapy, occupational therapy, social work, case management, and geriatric trained nursing in a closed unit where we get to take care of patients, the elderly population.
is there any other centers across the
There are.
United States that are doing
Yeah,
acute care of the elderly?
but there isn't that many.
Yeah.
So we're lucky to have our own unit.
And so you have like geriatric fellows and residents rotate through there?
Yep, family medicine and internal medicine.
Interesting. So how, in working in that setting and training some of these learners, what is the things that you're hoping that they'll take away from their experience in the acute care of the elderly? And how do you kind of explain the role or in the idea of like a SNF to your learners?
Yeah. So the first question is, how do they need to learn to manage these patients? I think geriatrics it takes a lot of a holistic sometimes
Yeah.
thinking approach, because you've got to not just look at just the patient, you're also looking at the family and what else is going on. It's not just all these guidelines that we have.
Right.
So that's when you have to put a hole to it and say,
Right.
listen, look at the patient.
Yeah.
What can
It's
they
not
do?
easy
What
as
are their
like a
goals?
protocol. Do this, this, and this,
Exactly.
and this.
That's when the protocols break down. That's when the residents
Yeah.
need that guidance
Yeah.
to understand what geriatric really is and what we can and we cannot do.
Yeah.
And to help manage. And then the big piece is teaching them what a SNF is. They don't know what that is. They're always discharging or accepting patients policy from a SNF, but they're like, we've never been to one.
Yeah. I always hear when I like rotate in the hospital, oh, they went to a SNF and they came back. They got horrible care. It was horrible for them.
Of
What do
course.
they even do at a SNF? They don't understand kind of the complexity nature
Yeah.
of like a SNF. Tell us a little bit more about how you try to navigate and help your learners understand what a SNF is and the complexities they're operating and how that works within the overall healthcare operating system.
Yeah. So I think explaining to them what a SNF can handle and cannot handle, because there's only so many things we have there. And I
Right.
think the biggest point is when you tell them how many nurses, like an LPN, it's not a BSN
Yeah.
or an RN, they're LPNs. It's a different side of training. It's
Yeah.
like 18 months. And how many patients they take care of, that is their eye opener. And you got their attention.
Mind-blowing, right?
Yeah. So we're talking about 20, 25 patients
Right.
per LPN. So when they hear that, they appreciate how much it takes for a patient, like how much care they're getting. It's not the same acuity as in the hospital. So
Right.
I'm always emphasizing, what do you expect your patient to get once they leave here? Do they still need that high level care? Then they're not ready to leave, right?
Right.
But if they're gonna go there, set them up to the patient to say, hey, when you get there, you're not gonna have one nurse that's gonna be just taking care of 3 or 4 patients. It's gonna
Right.
be a lot more. So understanding that, and the nuances when you're writing your discharge summary, what information are you relaying? How like jargon is it with medicine versus are you going to give them more clear instructions, starting and stopping of antibiotics or changing of meds that we've made, any dietary changes, right? Because that's a big important piece.
Right.
Or any like physical therapy notes about weight bearing status, because all that needs to be written in there.
Some of the complex kind of transitions in the care that I see are also around like anticoagulants. So
Oh,
they
yeah.
go into the hospital. It kind of naturally switches to like short-acting insulin because you can gauge and do it easier in an acute care setting, and they're not maybe transitioned back to their DOAC that they were on for AFib. And so they're coming back with these like complex like insulin orders for a nurse that now is taking care of 30, 40 patients
Right.
that they're just assuming, because some of these patients going to the hospital and coming back, that the progressive orders that there were before are not the same when they're coming back. So you had introduced yourself as kind of a expert in transitional care.
Yeah,
Is that fair to say?
I would like to be.
I think
like
I
that.
will call
like
you an
it.
expert. It's
I
good.
do like it because I do it because I'm working in the SNF setting as
Yeah.
well, accepting patients and sending them out, and
Yeah.
I do outpatient care, and I do the nursing home piece.
Yeah.
And the
So kind of break it down for us. Is like, what does transitional care mean? Like
Yeah.
simply transitional care, and what are the complexities and difficulties of operating in kind of that operating system of transition of care?
Yeah, so we look at transitions of care in different places, even coming from the ICU setting to a medicine floor.
Okay.
That's a transition.
Yeah.
You don't have to go from one building setting to another
Yeah.
building, right?
Interesting.
We talk about that.
Yeah.
Once they're from inpatient, they go to a nursing facility. That's a transition. From nursing facility to home, that's another transition.
Right.
Or back the other way. So any change from level of care to another level, I define that as transition. And there's just so many spaces for error at that time. So
Right.
that's why it's so important for our complex patients, the communication.
Right. And what areas are you working on that you've seen help improve that communication as you transition care? What are some of those steps or things that you're working on that you've seen help in that transition of care?
Right now, I think when we talk about discharge summaries, when we're telling our residents, explaining to them why this is so important, in the discharge summary, we're trying to kind of get the 5M model. We're just, if they can think
Yeah.
about the 5Ms and kind of say, when I'm discharging the patient, should I be thinking about this?
Right.
So that's what we're trying to do in the discharge summary, really emphasize any medication changes, any mobility changes, mind changes, all of those kind of things in there and what really
Interesting.
kind of matters.
So for us, for maybe those who haven't heard of the 5M model, like what are the 5Ms that you're like focusing on and worried about?
So mind is something we're going to always talk about. See if there's a lot of times in discharge summaries are beautiful, but they'll never write what the patient's mental status is or how they were when they were leaving the hospital, even though when they'll do a physical exam the day even of discharge, but it'll never really say that. So it's important for
Or
us
it
to
was
know
copied
and paste
for
it.
7 days before and
That
there's no
happens.
change.
Yeah, and they know it. I mean, we
Yeah.
all know it. It's just that
Yeah.
we don't take the time sometimes to write it. So
Yeah.
that mine is very, and then if there's depression or things like that. We talk about medication. Medication is really important because you want to talk about any of the changes we made. Because again, medication errors, as we said, they leave a nursing home and they say, I don't want to go back there. What if they go to another place? They may not have the same records. Or they're
Right.
back and forth in the hospital and the medication changes are just constantly happening.
Yeah.
So that's really important.
And
Or-
2026, and nursing homes are still using fax machines for sometimes discharge summaries, which is like mind blowing to me. But
yeah.
so there's a lot of room for complexity. So
Oh, yeah.
got the mind. Sorry to interrupt.
Yeah, no, it's okay. We got mind medicine. And then let's talk about multi-complexity that you just said.
Yeah.
Right?
Right.
That's really important because they're going to come with not just one issue, it's going to be a lot of other issues that we're going to manage. And of course, family, right? And that kind of bleeds into the what
Families
matters.
aren't hard though.
Oh, no, not at all. They're very understanding of everything. So that piece is important, the family piece, because then what matters most to the patient versus what the family's thinking, right? Every patient, most of them like, why am I here? I don't want to be here at the SNF, right? So if the conversations were had in the hospital, sometimes it's nice to know who did they talk to? What were their thoughts? Is a patient going to do rehab and then go home? Because that is our goal.
Right.
Send them home.
Absolutely.
But
yeah.
knowing what their goals are, the
Right.
patient could be like, I don't want to do therapy. I just want
Yeah.
to be home, right?
Right.
Understanding those nuances is really important.
Right.
And understanding what their other medical issues are. Just because they went into the hospital for a fall, we can't not take care of their pain that they've had from a chronic back issue or other cancer issues or anything like that.
Right. The other thing I think sometimes is interesting is the addition of like multiple different medications as they're coming out of the hospital that maybe aren't administered in a long-term care setting. So making sure we're also adapting some of those orders to what a SNF can even do or
Right.
expect them to be able to do. So,
That is important because sometimes we'll have the families bring them from home because we can't order them because they're just so expensive. Or,
right.
Yeah.
Right.
So keep that in mind.
Yeah, so in terms of like evaluation for a patient that's coming to a SNF, so now like put on your other hat, you're at the SNF,
Mhm.
you're like now seeing this patient for the first time. A lot of our providers now have never seen this patient, have the discharge orders in front of them, and need to evaluate for admission approval for medications and all of those things. What are the like big things that providers should be paying really close attention to in terms of like complex errors that are naturally happening from a transition from a hospital to a SNF?
Definitely looking at the medication list is the first thing they ask us to do because the nursing staff wants to put the medications in so the patient can get them, right? Definitely looking through the list, making sure there's no duplicates, because sometimes you get benzos that are just duplicates from the past. Pain medications, I've seen Dilaudid and I saw Oxy. I'm like, are they both really needing that?
Yeah.
So clarifying a lot of those kind of things, clarifying any blood pressure medications. Are there just duplicates, like dosing, if there's been changes? So that's really important to keep in mind. And then a lot of times, control medications, you need to have scripts for.
Yeah.
So Oxy.
The hospital never forgets to put a prescription in the.
No.
Oh, it's so frustrating. Providers, probably one of their biggest gripe is these orders are coming from the hospital and they don't have a script with them and they have to write them. They don't even know the patient. And now they're kind of risking, is this a new prescription for oxycodone, or are they tolerating it well? And so, I don't know how to help hospital discharge providers understand like the importance of
having them
just having a signed script coming out too. So good. Another kind of medication duplicates, like other things that you're like should be zeroing in on as you're evaluating admission.
Yeah. So the scripts, also want to mention, it's not just narcotics and the benzos. It's also Vimpat, which is an anti-seizure med, and Lyrica. They want scripts for that. So just wanted to mention that. What else for medication? Time dates. Like a lot of antibiotics, nursings might not know the indication sometimes that it's a 5-day treatment versus a 7-day treatment, because they're just telling you they're on this antibiotic. Doc, how many days do I keep it? So if you have an end date, start date, it's good that we can initiate that then, so we're not giving extra doses.
Yeah, a lot of times I see, especially in a SNF setting, is because there's no stop date, some patients are on things for no like exaggeration, like over a year. And then we're like, wait, why are they on this medication? Because the nurses don't necessarily appropriately have the training to be able to recognize, or they don't have the time to like simply evaluate, and they're checking boxes, say this medication, this medication, this medication. And so they're not complexly like looking at the overall like picture of the medicines they're giving these patients. So duplicates, like I looked at that, but I need to make that as like a mental checklist for me to like make sure to look at duplications of medications that are coming out. So.
Yeah, because a lot of times these EMR pick up, if you didn't do appropriate like when they first come in, medication reconciliation, it won't cross over properly. So, and it's also a different providers doing all these steps, right? Someone's admitting, someone's managing them, and the day of discharge, of course, it's a different doctor.
Right.
That's meeting them for the first time.
Right.
So,
and it's so hard because you don't know the patient.
Yeah.
And these are medically complex patients. These aren't like your healthy person that's coming for an annual exam that's on no medications.
Right. And it's not
30 plus medications sometimes that they're coming in.
Exactly.
So, no, I think that transition care from like the hospital to SNF is sometimes a little overwhelming for our providers because they're making kind of a quick snapshot decision on a patient that they don't really know. So discharge summaries completion is really helpful. So then on the reverse, what would you say, putting on your hospitalist hat, like a patient coming from the SNF, even to an ER or to the hospital, what are the helpful things, if you had your wish list of information that you could receive from a SNF, like what are the important things that we need to be communicating as we're transferring patients back to the hospital?
Back to the hospital. So they're at the SNF and something happened and they're going to send back.
For whatever reason, it's 2026 and the medical records don't communicate, which is like mind-boggling to me.
Yeah.
But like, what are the important pieces of information?
Of course.
Because at least within Vital Care and our like provider network, we require our providers to do a verbal handoff to the ED as the patients are being transferred from the SNF to the ER. So what is that information kind of in a quick snapshot? Because those ER doctors aren't used to that, frankly, and so they're really busy. What's like the top things that our providers should be communicating quickly, so that the hospital can get a bigger snapshot of like who they are and what's coming?
It would be really important to find out what has been going on. Of course, it's not just always altered mental status. What maybe led to that? Having a set of vitals would be really important. When was the last time they were their normal self?
Yeah.
To kind of get an understanding, what are we working with? If their baseline is this, is the ED doc going to say, well, no, this is not normal, and the patient just stays there, right?
Yeah.
Kind of getting that basic information is really good.
Right.
And of course, medications. active
Right.
medications, like what are they getting, or maybe even what they got that day before they were
Right.
sent out.
Yeah.
So we have an idea.
Right. The other really important thing, and I always try to stress this, is just simply code status.
That
Like,
would be,
what
yeah.
is the goals of care here for this patient?
Yeah.
Hopefully we've communicated with the family, or the patient understands why they're going to the hospital.
Yeah.
But like, if they get into a situation, like, what is our intent here in terms of like goals of care?
Yeah.
So like goals of care, medication, what's been happening with them are really important as
Yeah.
we transfer patients back to there. And the last thing that I really like to stress, and that I'm trying to change in terms of like the culture, is to help SNFs educate hospitalists
Right.
about what we can do in the SNF, because
Oh,
I
yeah.
think a lot of times, if it's an IV antibiotic appropriately so on formulary, you don't have to admit them to the hospital. We actually could have them
Manage.
come back to the
Yeah.
SNF, and it's their regular setting, and it might be better for them
Yeah,
in
this is
general
true.
to come back. So two-way kind of communication. Any thoughts on like how to improve that? Because I think there's such like a huge breakdown in this transition from hospital to SNF, but also to SNF to hospital. I don't know. Maybe there isn't I
Yeah.
don't think it's an easy answer, but
No, there isn't an easy answer, but I guess having an EMR that would talk, and I know that's asking for a lot, or even saying that verbal
Yeah.
transfer, like
Right.
call, would be, that's great. We don't really do that. We
Yeah.
do that because we work in the health system where we
you're
can
kind of
do
the
it.
same
Yeah.
communicating provider,
And we
which
can
is
write a
awesome.
little note. We can
Yeah.
say it's doable, but
Yeah.
you're right. I wish there was a standardized way of doing it. Once a person comes in from a SNF, there should be a standardized way of saying, okay, we need to talk to someone, or some information that's relayed.
Yeah. So I guess we've tried to help the hospitalists understand the SNF side. What would you say to SNF side to help them understand kind of the environment and complexity that like hospitalists are working with as they're trying to discharge these patients? Like the pressure from insurance and the pressure from attendings who are saying, why are they here? What are they doing? How do we help SNFs understand kind of the complexity on the hospital? And a lot of them maybe have trained in that setting, so they understand, but what are the complexities within the health system that SNFs should maybe appreciate and understand more?
I think you're right. They should understand the pressures and kind of understand. I think it's the goals of the patient then at that point, like saying, hey, if they're ready to do rehab, ready to improve, and whatever we can manage, we're ready to take them, and understanding that, hey, if they need IV antibiotics, wound care, things like that, we can do them at a SNF. Allow us to do that here,
Yeah.
having the resources, so that you're not using the resource of a hospital, but
Yeah.
can be done at a SNF. And
So
not to be
what
afraid.
advice, if any, would you give to a clinician who's trying to evaluate going into like geriatric medicine?
Oh.
Where it's reducing, right? We're losing
Oh,
like
yeah.
geriatric, like informed care providers. Like, what would you say if we're trying to like pitch and sell to providers to be like geriatric providers? What would you tell them?
I would definitely tell them that I think it is a rewarding career. You get to work in different sites and really are able to make a difference. And it's just a whole different beast of how you're managing your patient. And
Yeah.
it's like in the SNF, I feel like it's my own little way of managing a lot of things and teaching the residents, teaching the geriatric fellows and medical students how life can be different as we all age, because that's really important. No matter, even if they go into different specialties, just seeing that we're all going to get older and how we can manage. Staying home is also a great option too, right? But that we're
Right.
not always saying we want to go to SNF, but the goal is let's get them home, how we can manage them at home and grow older at home.
Yeah. And then as like maybe a way to wrap this up, but I think it's so important, like the ultimate transition as we are navigating families and patients transitioning to maybe palliative care or comfort care. How do you approach that conversation, and any advice on like leading into that as families and patients to like help them navigate that?
We do that a lot.
Yeah.
Because in the hospital, you'll write that last note, or write last sentence, patient was recommended for hospice.
Yeah.
And so sometimes when they come to us, like, we thought we were in hospice. I'm like, oh, did you? I was
Yeah.
like, this is not hospice, but hospice is more of a philosophy, or palliative care is more of a philosophy of
Right.
how we're managing the patient or
Right.
your loved one. So we talk about it quite a bit. Once we read the summary, and we're kind of like, where are you? And then therapists will come with us. It's not the first thing I do when I meet them. I want them to have the opportunity to do therapy. Unless they're there already, I'm ready to talk about it. But
Right.
hey, therapy's not really working. Your loved one's not eating. They're in a lot of pain. We would love to talk to you about what are the next goals. Even if you go
Helping
home, I want to
families
help
come
you.
to this conclusion rather than have regrets later on. Yeah.
Exactly.
Yeah.
And just offer them what the services are, because sometimes they don't know. We don't know the difference between palliative and what hospice means, and where you can do hospice. You can do it at a SNF actually,
Yeah.
right? Versus you can do it at home, but it depends what kind of supports you have.
Right.
So I have to be also mindful of what kind of supports I have. So before I offer.
Yeah. And I one of the big things I try to stress, like as palliative or hospice conversations, I think families feel like maybe they're giving up. Like,
Yeah.
hey, I'm giving up on my loved one.
Yeah.
But rather it's like focusing on their goals of care, and can be one of the most compassionate decisions you can make for loved ones, and helping them navigate that process. So
Yeah.
I think broader transition of care kind of opened my eyes today. I always think of, just because I'm in the trenches here, the transition is from the hospital to the SNF.
Yeah.
But like there's so many levels of transition of care, even acute care to maybe a patient has to go to long-term care.
Yeah.
There's so many different transitions of care. So
Yeah.
anything last budding information or advice you want to give on any of the transition of care process?
Yeah, I think it's a team effort at the end of the day.
Yeah.
We all have to work together for the patient and best outcomes. So if we can all kind of put our heads together and say, hey, what can I do to make this happen better for the patient and for me, to say, okay, we did everything we can for the patient, right?
Yeah.
I think that's where it's going to be.
That's awesome.
And that
great
including the
advice.
family, including what the patient wants. So
Yeah, I love the work you're doing. That is so cool.
Yes.
We stay in contact, and we can
Yeah.
talk more about.
For
I
sure.
have some really cool data research that I'm wanting to do too.
Yeah.
Maybe some of your fellows would. We have so much data on some of this transition of care stuff that
Yeah.
I'd love to like maybe parse out. But I have kind of a favorite part of my
Oh yeah.
podcast.
Yeah.
It is called SNF This.
Okay.
So I have some
Oh,
things I
gosh.
want you to sniff and see if you can kind of pick out what it is you're smelling.
Okay. It's minty. Is it Milk and Mag?
Close. Pepto-Bismol.
Pepto-Bismol. Okay, that's what I. Yeah. Okay.
You'll get this one. You'll get this.
Huh. Oh, it's Vicks.
Yeah,
Oh.
vapor rub.
Vapor. Oh my
Yeah.
God, your brands are okay. What? Okay.
We are brand agnostic here.
Sorry.
Good.
Cranberry juice.
Oh,
No, wait. I just
interesting.
changed my mind. I changed my mind. I don't know.
I want to see. I'm trying to see like cranberry juice here.
The color.
I can appreciate cranberry juice. NyQuil. I think that's a brand.
What is it?
NyQuil.
Oh, NyQuil. Oh, I was like, what's that? Now we're going backwards. Oh, good God. I think I sniffed it too much.
Gotta be careful what you sniff.
I know.
In a sniff.
In a sniff. Oh, that is true. It's like blueberry. Like, I don't know. It's some kind of syrup. I don't know.
Grape.
Grape. It has that grape.
Tylenol.
Oh, okay.
Acetaminophen.
Oh, okay. Okay.
Just kind of a fun thing we do. Like,
Yeah,
on
no,
Sip
that
This.
is
So
fun.
We really appreciate you being
Yeah.
on today, and for helping us understand the importance of transitions of care. And so, great.
Yeah.
Very nice to meet you.
Very nice meeting
Hope
you
to
too.
stay in
Thank
touch
you.
with
Thank you.
Yeah.
Yeah, for
Take
sure.
care.
Thank you.
Before we conclude, huge thanks to our sponsor, VitalCare Connect. Whether you're burning the midnight oil or just trying to survive another 2 a.m. call, VitalCare Connect provides on-call medical director support whenever you need it, nights, weekends, and holidays. With coverage nationwide, they're leading the way in post-acute care, elevating quality, expanding access, and supporting well-being for all. Learn more at vitalcare.org. Thank you for joining us for this episode of SNF This. Share this show with your favorite CNA or anyone who's survived an all-staff meeting fueled by cold coffee. Until next time, I'm Chance. In skilled nursing, if you sniff something, say something.